It is my great pleasure now to introduce Dr. Simon Towler. Dr. Towler is Chief Medical Officer at the WA Department of Health. He previously served as the clinical lead for end-of-life care and voluntary assisted dying provider with WA Cancer and Palliative Care Network. He is the State Medical Director at Donate Life WA, an organ donation agency in WA. A retired intensive care specialist of 32 years working at Fiona Stanley and Royal Perth Hospitals. He holds fellowships in the College of Intensive Care Medicine, the Australian New Zealand College of Anaesthetists, and I know it well, I was going to stumble, and the Australasian College of Health Service Managers at the AMA. Please welcome Dr. Simon Towler.
Good morning, everybody, and I think I should start by saying what they said. They've said it all. But look, thank you very much for the invitation this morning, and I really do appreciate the opportunity to be here. I want to extend an acknowledgement from the Director General, who's actually attending the Health Ministers meeting the last 2 days, and he commissioned me to be the person who would join you. And I would say I am passionate to be here. I do want to acknowledge the traditional owners. It's a lovely morning here on Hackett Drive. We are fortunate to be living on Noongar country, and they have been excellent custodians of this land, and I think we need to raise our game a bit, but we'll look forward to doing that. In terms of the conversation today, I was asked to particularly address the IGAP Recommendation 1. Well, this is kind of like walking into the swamp. Let's try and work out how this goes forward. No, that one doesn't work. Anybody can help me here? Oh, big button, that helps. For those of you who bothered to look at this document, which seems to be sitting at the middle of today's conversation, you will recognise, as you've heard, that it represents an important step forward. I think there was optimism in what we heard in the opening presentation around the potential impact of having a WHA recommendation for which all governments are committed. This first one, the idea of raising policy prioritisation and strengthening governance, is an ambitious target. There was an expectation in what you heard that governments will commit because the WHA has endorsed the program. And I think you heard a lot about how that works from our colleague from Neurology 1. How does it work? It works because governments are committed through the WHO and the Assembly to those resolutions which are passed. There is an expectation that there will be a response. Is there evidence that this works? Well, I've had a particular interest over many years in transfusion medicine and blood product use. We got a resolution through the WHA a number of years ago, and the international changes that are occurring in transfusion practice can be demonstrated to have come from that engagement through the WHA. In governance and prioritisation, Australia is a tricky place to work. We have a very disconnected health system. We have the state government responsible for certain clear accountabilities in partnership with the Commonwealth, who has other parts of the responsibilities. And in this sector, as you've heard, the role of community is profound. So you could feel very quickly overwhelmed. But what I want to acknowledge to you is there are a group of things in this state which make WA extremely well positioned to take advantage of this initiative. Firstly, I want to acknowledge the Council. I was in the CMO's role now more than a decade ago. We established health networks, and the first network that was effective was the Neuroscience Network. And it built on the relationships that existed through the Neurological Council to the societies that you well know. We started an initiative in that period around stroke. 2 decades later, Western Australia has been transformed in stroke care and is a living example. But in the broader discussion, what else do we have in this state that makes us unique? Who's heard of Professor Gareth Bainham? Gareth is a world international leader in rare diseases. What are a lot of neurological diseases? Rare diseases. Gareth has attracted more money than you can imagine. He is the heart of the international network of rare diseases. He is an absolute giant. And he lives here. He's a paediatric geneticist. We are privileged. Who's the Western Australian of the Year this year? Do we know her? Professor Samar Ayun, a specialist, works at the Perrin Institute. She is the Western Australian of the Year because of her leadership in community, compassionate communities, her work over years in palliative care. Is this an important issue in neurological diseases? Yes, it is, and it is part of that framework. So it's a privilege for me to be here today, but I must say I do feel vulnerable as the representative of the department after Etta's opening presentation. So we all know what this is about. When I first looked at IGAP, I thought, International Global Action Plan. Then I thought I'd better look at these words a bit more carefully. The first word is intersectoral. You've heard it, you know it. One of the interesting issues about the about the role of the WHO is it has a very big focus on less well-off countries and global burden of disease, as you've heard. So it's important we think about what the role of a well-to-do country is in the context of IGAP. Is neurological disease changing? Well, all of you will know that in the last few weeks we've heard that maybe there is finally a drug which makes a difference in the management of early Alzheimer's. But the cost is going to be enormous. So again, we have to remain joined up. We're very pleased that something is beginning to happen, but this is a challenging space. Now, you've heard about the IGAP. The original resolution of the Assembly was in what year? Anybody tell me? 2020. There was a small accident in 2020. The world came to a halt. As an intensive care doctor, COVID was a truly disruptive influence. Many, many initiatives ran out of steam during COVID because we had to protect our community. WA was one of the most successful places on the planet in terms of surviving through the COVID process. But a lot of things slowed down. And one of the interesting things about the WHO is the 2022 document from April this year showed that work did not stop on the IGAP. And the World Health Organization framework gives guidance and indicates who is responsible for different elements of the work. That is extraordinarily useful. The global focus is on disadvantage, but we need directed leadership. So, how do you leverage this outcome? How do you work on the fact that there is an international commitment to improving neurological diseases, because that is part of what the lesson is going to be from today and why it relates to strategic objectives. So these were the 5 things, and you've heard about them, and I won't repeat them, but we're focusing in this talk on raising policy prioritisation and strengthening governance. So what can we say? Well, not only is our opening speaker very committed to this, but the World Neurology Network has been talking about and espousing what is being achieved to date and what the opportunities may be. The resolution in part, though, was interestingly, for those of you who don't know how the WHO operates, somebody has to promote the idea. Somebody has to sponsor it. They have to come forward with a legitimate case. I was kind of curious that this was the Russian Ministry of Health, to be honest. Just in the middle of everything else that's going on. But the WHO took this on board as an important priority. It was sponsored and adopted by all members. So, what do we know about this? Well, you've already heard. You've already heard that neurological disorders are the leading cause of disability-adjusted life years lost. You know all this stuff. You're in the sector. You also know it's the second leading cause now of death globally. What does that all mean for us? Well, in terms of the 5 conditions which are identified in the document, stroke, migraine, dementia, meningitis and epilepsy feature as the most prevalent. And as you've heard, there is strength though in working together. Stroke is a huge issue. You know the history of stroke in WA and how much we reduced it? How much did we reduce stroke and what did it? Stopping smoking. Although there's more patients now with stroke, that's not because we have not done something about prevention. Age-corrected incidence of stroke has continued to drop and has fallen by more than 50%. If we had not had the smoking intervention, our hospitals would need stroke units that were 3 times bigger. The prevention piece is part of sustainability. So as is emphasised, prevention and the community level activities are critical. What else do we know? You heard about what the goals are: reducing the stigma, the impact of disease, the burden of neurological disorders, but also the associated morbidity and mortality and disability, because they sit at the heart of the conversation about quality of life. This falls into this first strategic initiative. So, as you've already heard, and this is a bit of an issue for us, the thing about burden of disease, the parliamentary member actually had much more up-to-date information than I had, but this has been around for a long time. We know that the neurological diseases have this pattern between disability loss and what is mortality in our society, because we have good systems. And in fact, stroke care in this state has improved enormously. I thought Darshan Gill was going to be in the room. I was going to point at him at this point. But we now have, courtesy of the government support, thrombectomy services for people with acute stroke. And as an intensive care doctor who's looked after those patients, it is absolutely transformational to see somebody come through the door densely hemiplegic and 2 hours later sitting up talking to you and the limb is moving again is extraordinary. And Western Australia was a leading jurisdiction in the world through the work of Trevor Apsheim in interventional neuroradiology right back to the beginning of this process. We have an extraordinary team. But the thing about hospital care is, as you've heard, it does little about this bit at all. Defining the hospital's role in the management of the non-mortality elements and morbidity is a really critical issue for us to resolve. You've already heard, and you understand without question, that the reason this is getting to be a bigger issue is this population transition. These are the famous diagrams of population in WA. This is WA information. This is 1970. There weren't many people over 70. This is 2001. It's growing a little bit. And now we have the coffin diagram. The fastest growing cohort in our community are the elderly. Who has the neurological disorders? The elderly. Who are the people we're trying to support towards the end of their life and maintaining their quality? A lot of them are older people. It's not to deny all the other people in here with neurological diseases, but this is a major issue and creates a really important challenge in what we address going forward from an investment decision, our planning and our models of service. So, is there a history of impact? This is a wonderful diagram that I've used for years. It's quite old now. It's from Theo Voss's work, looking at burden of disease and mortality patterns. This is the disease profile with causing death for men. This is the disease profile causing death for women. This doesn't mean that less people are dying. This means that less people are dying younger. This cohort here is cardiovascular disease. 50 years of intervention has dramatically changed the outcome for cardiovascular disease. So the theme of IGAP 1, work together, is important. This was infectious diseases, these are other things, but investment and commitment over time changes the outcome. So where are we going to go? We need new models of service, not just new models of care. We need to recognise, as was evidenced and as was stated in the IGAP program, that it's about the evidence and pursuing the evidence as part of the overall governance and IGAP 1. And to do that, we must never lose sight of the three elements: the research, the clinical expertise, and the patient inclusiveness in what is true evidence into practice. Margaret Murphy, I had the privilege of meeting. She was the head of the International Health Consumers Organisation, and constantly reminds us that we can do nothing about us without us. But when you're well connected, as the Neurological Council is, to patients, people and families, you understand this aspect of evidence into practice and what it means. Patient is the only one at every stage of the patient pathway. So are we good? This is a very old slide, and I use it endlessly because it's almost the only published slide of this piece of information. This is an American study. These are a range of disease conditions. There's a couple in here that are neurological: headache, and a couple up here. This is when Glenn reviewed the records of over 40,000 admitted patients and asked the question, to what extent are we providing the recommended care to the patients with these disease conditions? This is the mean, and these are the standard error bars. If you happen to need a cataract extraction, an lens implant, you get very high quality care most of the time. If you have breast cancer, and breast cancer is not easy, it's complex, you get good care most of the time. This data is 20 years old now. What's one of the really unique aspects of breast cancer? The community support and influence from the breast cancer community is profound. Influence from community influences quality by commitment and investment. Prenatal care, pretty good. Coronary artery disease, as we would have guessed from the survival figures, pretty good. But look down here. This is the 50% point. Headache is managed consistent with guidelines, and this is hospital admissions, about half the time, and almost no variation in what's delivered. Something is not working. The evidence into practice piece is significant. This has been a profound slide in thinking about the ongoing responsibilities of the hospital system to deliver care. So we recognise that clinical practice and models of care need to be driven by the evidence. We know the gaps. Well, fortunately, the changes in the way we use data and information are accelerating the uptake of evidence into practice, a governance principle embedded in IGAP 1. Part of the issue for all of us, though, is this. This is a diagram showing the number in each year of the high-quality evidence being produced from international research. Look at the growth in high-quality evidence over recent years. This is not related just to neurology, but how do you manage that? How do you ensure it is taken up? This is very much part of the IGAP 1 concept. And we need to stop looking back all the time to work out how we do things and looking to move forward. Health is a beast. It is a complex system. It is an adaptive system, and we don't do it that well. We are no longer working in a simple model where one doctor provides the patient with healthcare, and you know that profoundly well. Interestingly, though, hospitals are great places, and I've spent 44 years of my life working in hospitals. I kind of like it. They're complex, and we get very invested in them. And in the state government, we invest in them at an unbelievable level. I was privileged to be part of the commissioning team for the Fiona Stanley Hospital. Being given the keys to a $2 billion building and told to turn it into a hospital was one of the most interesting things I've done in my life. But one of the problems is, and you know it better than anybody, hospitals are not the fulcrum on which you deliver care. They have clear responsibilities, and our governance systems need to acknowledge that. The state government has an absolute responsibility to deliver the hospital component, but how we learn to deliver the other component is really where this sits. This is a little map of the health system. I'm not going to say anything about it. Nothing at all. There's a map of the health system. I hope it's helpful. So, for the clinician, we have hundreds of variables. We have guidelines that are growing. If you need to keep up with the evidence these days, you need to read 21 guidelines a day. Absolutely impossible. Translate knowledge in a consistent way from evidence-based care. Unwarranted variation becomes an issue when you can't keep up with the evidence. We don't have the tools to support them. But what I can say is the state has made a decision to invest in an electronic medical record, and we will have much better tools within the next few years. We are worried when things don't go well about the legal costs, and overall it is fundamentally very, very difficult at the clinical fulcrum. So I had the privilege of going to Intermountain Healthcare a number of years ago and doing the advanced training program in health service redesign. Professor Brent Janes is an extraordinary person. Combining a surgeon and a mathematician may not appeal to you much. Brent is an extraordinary mathematician, but led the reform agency at Intermountain Healthcare. And the point here is that clinicians are the only ones who have the fundamental knowledge about the clinical component. But they don't control the systems that set the context within which we work. There is leadership needed, and it needs to be easy for them to do the right thing. Intermountain Healthcare did an extraordinary thing. They said, we don't run hospitals, we deliver health. They completely redesigned their healthcare system. They changed it into clinical programs, of which neuroscience was one of them. They saved 15% off the budget in 5 years and improved patient outcomes. I came back from Intermountain and said, I've got a really good idea. Wasn't an appetite to do it because it is a massive transition. But the point is, it is about understanding the linked up systems. Otherwise, we can't achieve what IGAP 1 is on about. So, the sum of human knowledge and the complexity of human problems are perpetually increasing, and you might think this was written recently. Well, it's not. 1920 something or other. The problems remain the same. The systems need to be better, and the organisations and the investment needs to give the tools to the system and join everybody up. So, in this particular thing, we are keen on integration, person-centredness, and prevention, diagnosis, treatment and care. This is a big agenda. Because the WHA has given us a framework and will continue to enhance the learnings and the shared outcomes, we have an opportunity to do better. We are working not in a technical system. This is a socio-technical framework which you understand well. All these things come together in terms of the pieces that are needed to address disease, particularly where there is lifetime disability. We did a lot of work through managed networks. We set up health networks. The neuroscience network was the first one. The stroke work started in 2006 and it has continued to deliver. What we don't have, though, are these linked up professional groups, which in Scotland have been shown without question to improve the delivery of care across the barriers. I'm a big fan of Jeff Braithwaite, who's at the Australian Institute for Healthcare Improvement at Macquarie in Sydney, where he's changed the conversation about safety in healthcare. This is largely based on hospital information, but the point I'm trying to make here is we need to move away from the idea of looking at the things that go wrong to looking at what makes success more likely, learn from all events, not just the adverse events, and build resilience in teams and systems, not just hospitals. We understand that quality improvement is about being curious about the work as it is actually done. And because your community organisations work directly with patients and families, you know this. And I heard the call this morning from Etta. Continuous improvement is part of the story, as we've seen in stroke, and changing upstream conditions influences the burden of disease and outcome. IGAP 1, as you heard, had global targets to do this. I think one of my problems is if this is the only target, that's not a big enough dream. We can actually tick the box on having some national frameworks and policies already in place. We have some functioning awareness programs. Don't limit yourself to the ambitions within IGAP 1. We can do better. The challenge under IGAP 1 is advocacy. You are advocating loudly. I hear your message. Policy plans and legislation matter, and financing in the end is the facilitator. I'm a big fan of Theodore Roosevelt. The credit belongs to those people who are actually in the arena, who have the great enthusiasm, the great directions in a worthy cause, who at best know the triumph of achievement and value, at worst fail while daring greatly, so that this place shall never be with those cold and limited souls who have neither, I can't read it because it's sideways, but the point is, you are the passionate community and we recognise it. We have in this state giants like Gareth Baynham, Samar Aoun, and people like Charlie Watson, and together we can do a lot more than we're doing at the moment, which is the theme behind IGAP. Thanks for your time.
Thank you very much. Thank you to Simon, and apologies if you felt like you were a bit of a target there, but you did very well. And I want to say that as one of the funded organisations in the neurological sector, we are very grateful for the fact that we do receive Department of Health funding. But you don't control the prevalence in Western Australia, and that is certainly increasing, and what puts a lot of our people under pressure. And I do recognise that there are many neurological organisations that are not funded, and I really applaud their efforts in maintaining the momentum.